Sometimes hospitals have to bill, and that's how they keep track of doing it.
But there's also something that's not talked about, and I'm just going to say it.
Hello, I'm Nurse Dad, former Navy hospital corpsman and current ER nurse, and welcome to my podcast. What is pretty doggone important in healthcare? Charting. C-H-A-R-T-I-N-G. Charting. Now, over the years as an ER nurse, I've heard my fair share of lectures concerning charting. Wait, two ing words back to back? That doesn't sound right. Concerning, charting. Concerning documentation. But I never heard the subject illuminated on by somebody who, for a living, actually testifies in a court of law in medical malpractice cases.
Until now.
Cue Nurse Stacey, a nurse expert witness with whom I interviewed for this podcast and who you'll meet in 15 seconds. To be clear, this is not a discussion on the importance of documentation. The focus here are the possible legal repercussions to poor charting. I mean, nurses have gone to prison over this stuff. This video isn't telling you what you need to do, but only to remind you to consult your leadership and to do what you know is right. I hope you enjoy the video and stick around afterwards because I plan to give away some free stuff. Yo, I wasn't done talking. Whatever.
Thank you for having me. It's my pleasure.
You're a nurse expert witness. Can you please tell me what that is?
Yeah, so a nurse expert witness is a registered nurse. I'm a registered nurse by trade. I work with attorneys to help determine the standard of care and help determine if a nurse did or did not meet the standard of care.
So according to Google, and this is the only time I'm going to refer to Google for anything, the 4 pillars you have to prove in any kind of medical malpractice lawsuit are such. 1, that there was a professional duty owed to the patient. 2, there was a breach of such duty. 3, injury was caused by said breach. And 4, it resulted in damages.
So how a nurse fits in there, that is what the attorney is trying to prove in a court of law. Where nurse experts fit in, we are the experts that teach the lawyer, the judge, or the jury about nursing standards of care. So what should or should not have happened from a nursing point of view.
We've all heard about nurse burnout and compassion fatigue, and it's very real. I know I've experienced it. But there's also something that's not talked about, and I'm just going to say it, charting fatigue.
One of the challenges that we have as nurses is we went into this profession to help people, to be hands-on, to physically help them in any way we can. I think it's important to first and foremost know the why in it. And I think that's where my mind always goes, is why do we do something? And I don't think people know why we chart. In my opinion, we chart for 4 different reasons. The first one is to communicate to other providers the work that we did or did not do. The second one is to keep generalized records of what was done over that stay, maybe for future care. The third one is quality control, to have the hospitals go in and see how things can be improved. And the fourth one is legal. To go through them, the first one, communication with providers. It's really good that a physician or a physical therapist or a respiratory therapist can go into that chart and see what was done an hour ago, a day ago, as well as follow-up care when you're leaving the hospital and continuing on your care down the road. Keeping records of what was done for billing. Quality control, you can go through the charts and see how many interventions were done and what it caused or what it didn't cause. So you can kind of get some analysis from that. And then lastly, legal. We want to make sure that if a case does go to trial, that we have the data for our experts to look at. And that is what I look at as the expert. I read the medical record. I read the data, get a picture of what happened. I also take into consideration physician testimony, which is the memory of the providers, nurses involved. So there are a few different types of evidence. And then there's also what the patient says in the form of a diary, calendars, written notes, or just their memory and deposition as well. So those are all the pieces of evidence that I look at. I think nurses should know, chart like somebody's going to read it, because somebody will, whether it's the provider, a hospital administrator looking for quality control, or a lawyer or a judge a little bit later on if it goes to a case, but somebody's going to read this writing. And that's what I don't think nurses understand. I think we just think we are writing down what we did, but we're really just taking credit for what you did. You're taking credit for all that great work that you did. You do things all the time. Just take credit for that work. Whether you think it's big or small, put it in there.
Yeah, to that point, I had a patient not too long ago that refused several things from the previous nurse. She was convinced finally to get back into bed, to be put on a PureWick because she was going to receive Lasix and she couldn't walk very well. Accusatory at times, she had said I didn't give her a particular medication when in fact I stood by the bed, I did a slow push, we had a discussion, and then she remembered. She said, "Oh yes, that's right, you did." I wrote that all down. Whatever that treatment plan looks like, whatever my experience with the patient was, I want to make sure it's reflective in the chart.
It's important to put the why. Why were they refusing? Was it because they were hungry and they wanted to eat first? Was it because they wanted their daughter to be next to them first? So I always say patient refused is not a complete sentence. Patient
Okay.
refused, why? And just explain the why. That way, when somebody is reading it, because remember, somebody will be reading your chart, you can explain the why. Not only do we have to assess, but we have to reassess. And that can be with medication that we're giving, with an intervention that we're doing, with a focused assessment that we are focused on. If a patient came in for breathing issues, we're constantly assessing the breathing. And so you want to do an assessment and as many reassessments as you need, but you have to make sure to reassess it.
In my experience, and I learned this early on in the emergency department in Queens, it's a lot easier to document as you go, at least in terms of recall and to ensure that everything is charted as you are doing it. Some people, especially younger nurses, I'll see them hang out after a shift and they're catching up on their charting. You're a nurse. What have you developed in order to ensure that everything is charted correctly?
So these are the 5 things that you shouldn't do when charting. Don't be vague. Don't be negative. Stating opinions versus facts. Being incomplete in your charting and waiting to the end of your shift. Being vague. Just writing something very generalized for the patient is not individualized care. And as we know, patients are different and everyone needs individualized care. So be specific. What did you do? How much water did you give them? How did they take the water? How did they tolerate the water? Be very specific when you're charting something. Being negative, you never want to put anybody else down. You never want to say you walked into the room and the patient looked like a mess. The nurse before you left her in a terrible condition. But on the flip side, you can say all the positive things that you did. You changed all her sheets. You gave her a full bed bath. You made her comfortable. You gave her an extra pillow. All of those positive things that you did, that's what you want to put in there. Don't try and be negative about the person before you. Stating
That's something
opinion.
that I do now. I'm sorry to cut you off. That's something I also do now as more of a seasoned nurse. Anytime the patient is bathed or changed in any capacity, especially since skin breakdown is so important, I always make sure I get it in there, whether I do it or the nursing assistant. That's just, again, that's something that can come back and get me later. So I always make sure it's done.
Yes, we do so much throughout our shifts that we don't write down, that we don't take credit for. Bed baths, walking patients to the bathroom, walking them in the hallway, giving them water or food, answering their loved one's questions, reaching out to a loved one when they ask us to. There's so many little things that we do throughout the day, and those things just don't get charted. But the good thing about it, you can put whatever you want in the chart. The chart is for the nurse to be able to chart what she did. So put it in there. That's what it's for. But people think that those are just so unimportant that, I'm not going to put that I went in and checked on them sleeping and they were still breathing. That could be a really important piece of the puzzle if that patient is not breathing 15 minutes later. You want it to say, I did my hourly rounding, checked on the patient breathing evenly and unlabored. Those little things that you don't think is important actually can be important, especially if it came to a legal suit.
There's not many avenues in life or situations where you say something and that's what happened. But when you document on the chart, it's a legal document, you did it. I guess it can be refuted to a certain degree by an attorney but as far as I know, if I did something and I documented, I did it.
Yes. And when you put that in the chart, an expert who's looking at it can take that into consideration. Now, any one piece of evidence in a chart is never the end all be all. Usually, I would say, you have to look at all of the pieces of evidence. And what's written in the medical chart is one of the best pieces of evidence because it was written right then and there. And you don't want to it to be 4 years later and you're telling that story now. One, you'll probably won't remember it. But two, no one's really going to believe you 4 years later that this happened, because why didn't you just write it down when it happened?
You reminded me, that's right. I think a lot of people have this idea that if there's a medical malpractice suit, it's in the relative near future, but this could be 5 years or longer from your actual encounter with the patient, which only highlights the importance of documenting even more.
It's really hard to remember what you did 4 or 5 years ago on one patient. We usually have 6, 7 patients at a time. And if it was insignificant in your day, you might not even remember it. So it's really important to write it down in the moment. And like you said, go to the patient and then chart. Go to the next patient and chart. And as soon as you can chart it, that's your best recollection. That's your best memory that you have. You have all the details in there. Remember, don't be vague. You have to be detailed about it. What did they look like? And I always do the who, what, when, where, why. Who did it? What did they do? How did they do it? Why did they do it? Put in all those details and you're going to remember the best right after the encounter happens. Obviously, if there's an emergency, it might have to wait a little bit longer, but as soon as you can put it in the chart, put it in the chart. And then also make sure that you are back timing it to the time that it actually happened, so that you are again taking credit that you did it an hour ago. You're just sitting down to chart it now. And the chart will reflect that. It will show you're charting it at this time, but it actually happened at this time. So don't forget that.
That's such a great point. I've been guilty of it myself, especially when, I'm in the ED and I have 8 patients, 12 patients. I'm called to a code. I'm trying to get my charting done, backdating, because if you did a procedure or anything for the patient 2 hours ago, if you chart it now, technically you might be considered late. Vital signs have been in your pocket that the CNA gave you. Make sure you chart it at the time that you received it. Otherwise, you don't get credit when it was actually performed. You might be accused of something that's not true.
Absolutely. I've seen a lot of lawsuits when things are not back timed to when they actually happen. There's a lot of confusion, and then it's really just hearsay at that point. Did it happen? If the times are not accurate, it's really hard to put together a timetable of when things did happen. And timetables are really important when something negative happens to the patient. You really want to look back and see, could this have been prevented? Could this have been foreseen? So those times are really crucial to have them correct. So I recommend bringing a notepad, a piece of paper, something you jot down. Same thing with notifying the provider. Super important. Us as nurses, we're at the bedside, but we need to keep those doctors informed. They're depending on us to keep them informed. Whenever you notify the provider, again, jot down the little time and put in that provider notification. Take credit for that work. You notified somebody. So put that provider notification in there.
Now I carry something because I might have to do 4 patients consecutively on the chart because I'm just too busy, but at least write the time, when I got the patient, when they went here, when I did this, when I drew the blood, just to protect myself.
Because we can't be doing something and charting it at the same time, it's really important to make sure you chart as soon as you can, as accurately as you can by back timing and putting in all of those details and making sure that you are getting that information into the chart as soon as you can. Make sure that you are documenting facts, things that exactly happen. It's really easy for us to become emotional with the patients or with the situation, but try and leave your opinions, feelings out of it and just state facts. When stating facts, I mean quotations. What exactly did the patient say to you? What exactly happened? You are being as objective as possible when you're writing your notes.
Especially with a more aggressive patient, should they write what they said? Like you were saying, be specific, put like an objective spin, like the patient has been combative, has been verbally abusive, they said this, would too many quotation marks be perceived as having like an attitude? What is the appropriate way to, in this example, document a patient who's been combative, been trying to get out of bed, been throwing stuff? How would you document something like that?
It would be as honest as possible and put in as many facts as possible. I think as nurses, we do want to be professional in our notes, and that is absolutely we do. But saying something like they were combative, what does that really mean? Did they try and hit you? Did they knock over their coffee onto the floor? Did they throw something against the wall? I think it's really important, especially when it comes to legal cases, to know the details, not just for me to make an opinion on the case, but also the judge, the jury, whoever is deciding this case, they need to know, what does combative mean? So being
Right.
as direct, honest, and putting as many facts in there is really important to set the scene. Did you feel safe? And if you just said a patient was combative, sometimes I have patients that just airbox. I don't feel threatened
Mhm.
by that. But there are some patients that also have tried to hit me, and I did feel threatened by that. It is important to put in those facts and be as specific as possible to set that scene. Again, think about somebody is going to read this, and you want them to be able to have the most clear picture as if it is a video that they are playing back of what happened that day.
In a lawsuit that involves the entire medical team, is there any particular position, whether you're the doctor or the MP, physician assistant, the nurse, the CNA, is there one position that's usually more vulnerable than the others?
To answer that question legally, I would refer to a lawyer, somebody that has more knowledge in the actual legal case. My knowledge is just from a nursing point of view. But what I can tell you is that for the last 90 years, there was a rule, at least in North Carolina Supreme Court, that said that nurses could not be liable for following a bad doctor's order. So if the doctor had written an order and it was bad, it would be fully on the doctor. It was not on the nurse. Unfortunately, in August of 2022, North Carolina Supreme Court overruled that 90-year precedent and did say that nurses now are liable for bad orders of the doctor, meaning that nurses should have the knowledge to know if an order is unsafe, they can be held liable. So with these legal cases that do set these precedents, the rest of the United States can point to that one case and say, see, this Supreme Court ruled that nurses do have the autonomy to be able to understand, and they should have the knowledge and they should have known. But nurses can be held liable for doctors' orders.
Which in some ways makes sense. Like last week, I noticed that I was going to give Lasix to another patient who had a low potassium, not too low, but just a little bit. And they had ordered potassium to go with the Lasix, but didn't really feel comfortable because it was a PO potassium and a lot of Lasix, and I mentioned it to the physician, and I'm not sure if this was the original physician who ordered it, but she ordered more potassium supplement to be given through, later on in the shift as well, just to ensure that this patient isn't going to lose even more potassium with the Lasix. So that's an example of a nurse seeing an order and mentioning to the doc, hey, is this the absolute best treatment plan we can have for the patient considering the situation? But in some cases, many cases, I'm not a physician. There might be a medication I haven't even heard of that I'm gonna look up online and see what it does. But how would I know if maybe it reacts a certain way with another medication, or if certain levels in the blood are one way, maybe this medication isn't as effective? Like that. That's something that's pretty frightening to hear, because as a nurse, our knowledge only goes so far.
So I think it's really important that you recognize that you had that knowledge. You knew that a medication like Lasix could cause more harm to the patient, and you spoke up. That is the best way for a nurse and a doctor and other healthcare provider teams to work together to treat the patient. So if you don't have that background, speak up and say, I'm not comfortable with that, or I'm unfamiliar with that. One situation that comes to mind with me was a patient that was having an allergic reaction. A rapid response was called. The physician during that rapid response ordered to give the patient the epi. So when the nurse asked for the epi from the crash cart, an ampujet of epi was handed to her. Now that ampujet of epi is really strong epi. It is 1 to 10,000 strength for epinephrine, which we give to our cardiac arrest patients, our patients that are dead. She was unfamiliar that there were different doses, there were different routes that you could give epinephrine, and that our crash cart even carried different epinephrine. So she thought she was just following a doctor's order, ended up giving that epinephrine, really strong one, IV, and unfortunately the patient passed out. And when the doctor said, "What did you give her?" The doctor said, no, I ordered epinephrine 0.3 milligrams IM, strength 1 to 1,000. Now, again, an EpiPen, if you will. We've all been in rapid responses. We know how quickly things move and how orders are kind of given as the epi. Let's give the bicarb, the amiodarone. If you're not familiar in a rapid response of what those doses are, then step back. Don't give those medications. You can help in a different way. Maybe you can be the recorder. Maybe you can be the runner to go get something. Maybe you could be comforting the family outside the room. So if you're not confident with what the epi means for an allergic response, don't volunteer to push that med.
Hello, folks. I hope you're enjoying the interview. Before we go back, let me announce I wrote a children's book, Isabel Learns to Share, a love letter from me to my firstborn daughter, Isabel. It's available on Amazon, but let me be clear. In a world of AI, this book is written by me, every word of it. Everything this book earns goes right to the podcast. This book emphasizes family values, respects parents, and respects children as they go through life making mistakes, but ultimately learning how to become their best selves. Click the link down below, support the podcast, and get yourself a copy. Thank you very much.
Which brings me back to, you should always be asking questions. I tell myself there's no ego in medicine. If you're not sure of what something is, or you just want to know what a particular medication does, you never heard of it, just ask the physician. Some physicians are more approachable than others, but typically there's somebody there that can tell you what you want to know.
Don't be afraid to speak up. Nurses can be held liable for physician mistakes. So make sure that if you are carrying out a physician's order, that you understand it. If you don't understand it, just ask a question, ask for clarification.
I had a patient come in respiratory distress. She was on a non-rebreather, and he wanted to get a CAT scan. And I said to the doc, I don't feel comfortable transporting this patient at this moment because a non-rebreather, as you know, is not a treatment plan. And she's really struggling. And I've seen problems occur in CAT scan in certain situations where you're taking a patient who's not breathing very well. You're attaching her to an oxygen tank, a portable oxygen tank, and then you're going to expect her to lay flat. And in that situation, the attending came in, he agreed with what I had said, and that we need to stabilize the breathing first and possibly put the patient on maybe high flow nasal cannula or something that's not a non-rebreather mask before going to CAT scan.
Absolutely. Yes. And the other thing I want to point out is that not following a doctor's order can also be disciplined by your state board. So I don't want to give off the approach that you should not be following doctor's orders, because it's very important to follow our doctor's orders. But please review all of your orders as soon as you get there. And if you have any questions on any of them, ask for clarification. Some of these orders are old. Maybe they're from the PACU a few days ago. Maybe they're from an old ICU stay that the patient's been downgraded. If you see that an order is inappropriate for that patient, have it DC'd, because if it's there, it's your responsibility to do. So don't just say, oh, that one's not applicable to me. Oh, no, the daily weight, we're done. The doctor told me we're done. Make sure we get those orders out of the chart, because if they're there, you're responsible for them.
And in terms of making sure that the chart reflects what you're doing in real time, every time I get a sepsis patient, because I know as soon as they arrive, and when it comes to sepsis, there's a 7 or 8% higher mortality rate for every hour that sepsis is not treated. So I know someone's going to look at that chart. When did they arrive? When did the doctor assess them with the nurse? When was that bag of fluid hung? When was if they have a fever, maybe IV Tylenol? When was the antibiotic hung? When did they go on the cardiac monitor? Make sure you document all of that. One of the changes I made to my practice after a conversation that you and I had was a story about someone who was doing a one-to-one. Because I'll always chart that in a one-to-one, the patient is within arm's distance of the nursing assistant or myself, whoever's sitting with the patient. And you had mentioned that it needs to get more specific than that. And I thought this was a great example of making sure that what is happening is actually being documented. Can you just go into that real quick?
Absolutely. So the rule of thumb has always been within a arm's length, which is great. You absolutely want to be within an arm's length so you can make sure that you can intervene if something negative were to happen. But you can't intervene if you don't see it. My rule of thumb is within a arm's length as well as eyes on the patient. Unfortunately, I heard of a situation where a suicidal patient needed to go to the bathroom. The one-to-one went with her, sat with as she sat on the toilet, and they were within an arm's length. The patient did ask for privacy, which is a pretty generalized thing that patients do ask for when going to the bathroom. So the nursing assistant felt that it was okay if she turned her head to the opposite way and not physically watch the patient go to the bathroom. So she said that she heard the dribbling in the toilet. She heard the toilet paper dispenser unroll. She heard the flush, and she went to help the patient wash her hands. As the patient was washing her hands, she put water into her mouth, which was strange because that's not a thing that you do. And then unfortunately, the patient passed out. While they called the rapid response and the code blue, it was determined that the patient had taken the toilet paper and stuffed it up her nose and also stuffed it down her throat. And when she put the water in, it all disintegrated in her throat. So she wasn't able to breathe. Unfortunately, they were not able to get an airway on her due to the obstruction of the toilet paper, and she did become brain dead and die. I like to tell this story just to really show nurses and one-to-ones that you have to be within an arm's length and have your eyes on the patient. We never know if the patient is trying to harm themselves, if they're trying to harm us, and we want to be there to intervene. So please don't leave your patient's side for a minute to grab your cell phone charger or to grab a sip of water. It can only take seconds, and we could harm a patient.
I tell all my nursing assistants that story now, and when I document it, it's within an arm's length while maintaining, continuous observation. Because I could just imagine some lawyer somewhere interpreting, reading that was within arm's length and saying, "But did you have your eyes on the patient?"
But within seconds, a patient can get harmed. I like to tell stories to kind of bring it home and to really show what can happen in just a quick amount of seconds.
And stick up for yourself too. Make sure you put your foot down at times as a nurse. I've had my fair share of seizure patients wanting to walk to the bathroom, and I'm very insistent that that's not going to happen. And as if to prove my point, I remember a patient that I had said that to, well, not so much in those words, but like, you're not walking to the bathroom, being assisted in a wheelchair and having a seizure in his wheelchair. And that could have been a catastrophe. And some nurses, there's bullying, there's lateral violence. It's something that happens, but also document that if the patient was resistant or whatever the patient did to demand that they walk to the bathroom. I mean, ensure that they're not walking to the bathroom, convince them that it's not safe, but also put that in the chart that happened.
That's a really good point. And that's, again, being detailed. If they said something, and then you can chart it as reviewed benefits and risks. Patient understands their risks. Patient understands that it is not recommended for them to walk, but they state, I understand my risks. I want to anyways. Something like that, definitely goes a long way. Showing, and then as well, again, be as detailed as you can. Make sure that the patient is competent. Make sure that they are alert and oriented ×3. Write that in there. Make sure they are understanding. Maybe if a daughter is at the bedside, daughter Stacey agrees to this plan. Set the scene so that if somebody's reading that, they know exactly who was in the room with you, if the patient was alert and oriented, and what was said.
And check the charting before. This I saw recently where I received a patient who was an elopement risk. That's how it was illustrated to me. And they were an elopement risk. But the doctor had put in a one-to-one order for suicidal ideation, and it wasn't documented. When the nurse was on the electronic record, the last check, because it is a check, was it for suicidal ideation? Was it for self-harm? Was it for risk of elopement? It was risk for elopement, because that's how it was illustrated in the verbal exchange from her and the other nurse, and that's how it was told to me. But when you actually check the doctor's order, it was for suicidal ideation. So there had to be a correction made and a clarification.
That brings up another story in my head about not just trusting that something was done on a shift before you or should have been done. There was a story that I heard of a patient who had an NG tube down their throat. It was hooked to suction. It wasn't giving much output, so they wanted to do a abdominal CAT scan with contrast. The doctor ordered for CAT scan contrast to be put down the NG tube. When the nurse did this, it ended up going into the lungs, and the patient aspirated the contrast. And everybody said, "How could this be? This NG tube has been in there for 4 days," right? When they looked back in the charting, there was never an x-ray done for placement. There was never a doctor that looked at that x-ray that gave an order okay to use. And as well as the assessment that didn't happen every single shift saying, did they auscultate for placement? Did they check gastric contents? None of that was done. Everybody was just assuming that the person before did it. Please don't make any assumptions. Do your own assessment, write what you see. But I also want to say, don't document what you didn't do. If you were supposed to round every 2 hours and you didn't get to it because you got called to an emergency down the hall and you were in a code blue for 2 hours, don't write that you were in that room. We never want to falsify documentation. So please be honest, be ethical.
I always write to the beginning of the shift, patient endorsed from, because I don't want credit from before I get there. If I take a break for however long it is, make sure I write who I gave report to. I don't want credit for something that occurs while I'm on break. Not too long ago, I overheard a conversation between two nurses. The one nurse was working in triage, and the patient was going through a particular situation. She did what she had to do, and she sent the patient out for a higher echelon of care. I believe he had to go to CAT scan and so on and so forth. About a day later, I think it was it was another physician. It was a physician on the floor. Something hadn't been done. It wasn't anything really important, but she had pressured the nurse to just document it, just to have it in the chart. And the nurse was very uncomfortable about something like that. What advice would you give that nurse?
I would say if you didn't do it, don't document it. I understand that physician wanted the chart to be complete, but it is on the physician's responsibility to get the appropriate person to do it. Or if they oversaw it, they could also do it. But I would never write something that I didn't physically do myself. That is falsifying documentation that you can be prosecuted for, and I would think lose your nursing license for. I would tell that nurse, to respectfully say, "I'm sorry, I really don't know what you're talking about. I wasn't there." You could get your manager involved, your charge nurse, maybe the house supervisor, and say, "Hey, I understand this is really important to get documented because we want to make sure it's complete. I wasn't on yesterday, and I went to break an hour ago. This nurse has already gone home for the day." Maybe they can call her back in. Maybe somebody who else was there can say, observed nurse Stacey doing this. There are a few different ways to make sure that it gets in the chart without falsifying documentation.
And would you recommend for a nurse who's uncomfortable about doing something, or it's not even that situation, it's just something that's important to contact maybe the charge nurse or the nurse manager and then include that in their charting, that I spoke to so-and-so or so-and-so made aware?
I think for that, you could be vague and just say, made management aware. because you're not really sure what they're going to do from there. But I think we also forget as nurses that, especially when we're working in hospitals or stable conditions like a large hospital, maybe a clinic, there are many other resources. And I think we think that we have to do it all and we have to be the only ones that can do something. We have lots of resources between other healthcare teams, our charge nurses, our managers, even just a mentor in the hospital. We have educators in the hospital. And most hospitals do have a legal team. I've had a manager reach out to our legal team and ask them a question. It ended up being like a CPS or adult protective service situation. And we went to our legal counsel. They have somebody on retainer and said, hey, what do we do for this? How do we report this? As nurses, I want you to know there are lots of resources out there. You just have to use them. So please use them.
It's easy for a nurse to feel like they have to do everything because a lot of times the expectation is to do almost everything. I remember working at a place where the housekeeping union, they don't have to clean up bodily fluids. So every time there was urine or feces on the floor, the nurse had to clean it up. The housekeeping can clean up everything else, but then the nurse had to clean up those substances on.
You're exactly right. And I think it's important to know the why on them, because it does seem like housekeeping doesn't have as much of a hand in cleaning the hospital rooms as I had thought they would. But when I learned some of the whys on them, I understood the why. Now, should it be a nurse's responsibility? I don't know. But I do understand that they don't have as much medical training and knowledge as we do. And that's why they sometimes want the nurse to be involved in that. Something as simple as stripping the room, right? When a patient leaves, before a housekeeper will go in, a nurse has to go in and strip the room. We have to take the sheets off. And I would always say, it's not a hard task to take the sheet off the bed. Why can't a housekeeper do that? But when I learned the why is because there could be patient belongings like dentures, things like that in the bed, which again, housekeepers could thoroughly look for. But unfortunately, somehow a stillborn baby was left in a room on a stretcher. And when the family had left, they were in grief. They didn't tell anybody that they were leaving, and they just covered the baby in a sheet. And when the housekeeper went in, they just took all of the sheets and unfortunately threw out the baby with the sheets or with the trash. We're not really sure.
Wow.
So
that is wow.
So that's the why of why housekeepers are no longer qualified, if you will, to strip the room. They want a medical professional to go in and make sure that there's no medical things that need to be attended to before they do their cleaning. Again,
I think see that.
Again, does it have to be a nurse? No, maybe there's a nurse on staff with housekeeping, right? That goes around and just does that sweep. Because I do feel that nurses get a lot put on their plate, especially when they find these cracks in situations. They do just put more on the nurse, which is tough.
We used to make a joke that whenever the hospital couldn't figure out who was to perform a task, they would just add it as a nursing duty. But I could see what you're saying. It just has to happen once. That baby story is horrific. Something like that happens. I think everyone can agree in unison that, okay, that should never happen again.
I just want to say my spiel about the warning signs.
Yes, you do that, and then I'll wrap it up.
Okay. So one more thing I wanted to bring up that I like teaching when I do teach nowadays, one of the first stories I start off with, because I love stories and I love showing how something as simple as an everyday task can actually end up being harmful for the patients. So I think as nurses, everybody has used a IV kit. It's very standard, but not a lot of people have read this warning sign. So there is a orange warning sign on here, and it says, warning with 4 stars. Do not use ChloroPrep on children less than 2 months of age. I've used this hundreds of thousands of times on IVs, and I've never read this warning sign. It was only another case that I did where they had brought up warning signs and they had showed the jury how clearly warning signs are written in the hospital. And the jury, had said, wow, that's written really clearly. And I started seeing these things. I started seeing these warning signs. So I grabbed an IV kit and I saw this warning sign and I was like, wow, even when it's bright orange in your face with stars, you still don't read it. So please
It's like
read.
alarm fatigue. Like you
Yes,
hear,
it is.
you know that oh, that's been going off for like a minute. How did I not hear that? So yeah, warning sign fatigue,
Yes,
charting
they have
fatigue.
them with fatigue on everything. So please keep your eyes open, your eyes peeled, and read things. They're there. They're like stop signs. They're yield signs. They're there for your protection. We just have to use them. So please use them.
One of the things, and I'll wrap this up. One of the things I remind myself, and it's a little idealistic, but it kind of just reminds me to pay more attention, is pretend each patient is my mom, or I'm the relative of my mom. They need to be changed. Okay, you'll get to it, or you'll have someone get to it. But how long has it been? Or they are hungry. Is there anything you could do to maybe get that food order in? Or they need to go somewhere, or something needs to happen, or just questions aren't being answered that the relatives may have. I find that, again, it's a little idealistic, but it has helped me. It has shaped my care. Probably because I started out in a Navy hospital corps where everyone I'm treating feels like my brother and my sister. But in the civilian world, and my parents are getting older. I'm 43. I have said that to myself more than on occasion, and frequently actually, to remind myself, what if this is my mom? Is this being done to meet my requirements as a relative or as a patient? How could I ever expect my mom to receive A1 care if I'm not giving it myself? So just to kind of, because you do get so busy, and it is very difficult sometimes to not treat people as numbers. I mean, we are going by a triage scale. So sometimes people that are there first for something minor don't get precedence over someone who just arrived for, I don't know, chest pain or something like that, abdominal pain or whatnot. And just to remind myself, okay, if this was my mom, wouldn't I want her to be reassured?
Like that. I like that a lot. You should definitely treat the patient like they're your loved ones, they're your family members, and then also chart like somebody's going to read it. Chart like you're going to have to defend this a few years later in court. What do you want it to say? Family members are very important when it comes to legal cases. I don't know the exact numbers, but I know research has been done that when a family feels that they're informed or feels that everything was done, that they're less likely to sue. If they like the provider, they like the nurse, and they feel that everything had been done and that they were kept informed, they're not as likely to sue as somebody who really just felt disrespected. They felt like nobody kept them informed. They have no idea what was going on. They want answers. A lot of time lawsuits are just for answers for the families. They want to know what happened. My loved one went in for knee pain and died the next day and nobody told me why, right? They're really just looking for answers. So the more that we can keep our families involved, updated, and like they are our family members and we're working with them, not against them, in my opinion, they're less likely to sue. But
a series of small gestures that can avoid a lawsuit or cause one. It goes to show you just how much power you have. But Stacey, I really want to thank you for coming on the podcast. Got to have you back at some point. This has been fantastic. We're always told about the importance of documentation, and this is the first time I heard it from a legal nurse witness.
Thank you very much for having me. I love giving my knowledge. I love teaching others so that hopefully we can prevent some things in the future. I am in the process of making a charting for success course so that if you wanted to learn more about charting, how to document, what to do, you could take that course and hopefully not make the same silly mistakes that have been made in the future, and that you can successfully chart in the future. So stay tuned.
Thanks again, and thank you for giving your expert advice on this subject.
Thank you for having me. It's been my pleasure.
Hello, folks. I hope you enjoyed the interview. And before you go, I just wanted to share with you that I've produced 2 free guides. The first guide isn't just for nursing students, it's for all students. Time-saving techniques that I learned in the military and when I also was going for my bachelor's degree in nursing. I used to see students that would just devote all their time to studying and they pretty much would shut down their life. And for me, I was in my 30s when I was going for my bachelor's. I just couldn't do that. I had a life, I had hobbies, I had things I loved to do. I refused to give up all the things in life that I loved. So I put some tips that I learned in a little small book, less than 10 pages, very quick read. Please get it for yourself or for someone else. I guarantee you'll benefit from it. The second guide is actually exclusively for people in the healthcare business, specifically nurses. Time management, less than 10 pages. How do you treat patients and avoid burnout? There's a lot of multitasking involved, and it's just a little quick. Here's what I learned. A couple of steps, nothing major, but it might help you out. The links for both these free guides are in the description. This is a new channel. My focus is producing good content, actually better than good content. That's my focus. I'm a former bartender, a former bouncer, a former Navy hospital corpsman, a current nurse, a family man, sometimes a jackass. I want this to be a place where you can go and escape, maybe learn a thing or two, maybe be entertained, and at least see somebody who is like yourself, a human being doing the best that he can in the world.
Shush, you're going to make me cry.
Please like, share, and subscribe, but you don't have to. I'm happy you're here. Until next time, Nurse Dad out.